I come here today grieving. My sister died last summer of metastatic colon cancer. She was an oncologist, a radiation oncologist at Brigham and Women's Hospital and Dana-Farber Cancer Institute. Her name was Larissa Lee. She was 43 at diagnosis, and she was too young to have standard colonoscopy screening. As oncologists, we know when cancer screening is indicated. There are a lot of unknowns when a young person is diagnosed with cancer, particularly advanced disease. The main question is always, how did this happen? And after her diagnosis, we thought about this. We have no cancer risk gene in our family, and no one prior to her diagnosis had ever had colon cancer. We found out too late that she was, in fact, eligible for high-risk colon cancer screening. 6 years prior to her diagnosis, our brother had had a colonoscopy with an advanced adenoma. Advanced adenomas are the bad-acting polyps. They're the ones that you don't want. No one had counseled my brother about this result. No one had told him the significance of the result and that his sisters should have high-risk screening, as gastroenterology guidelines recommend. My sister and I were not keeping up with those guidelines. After her death, I saw her primary care doctor, and I mentioned this issue to her primary care doctor. And her primary care doctor also didn't know that my sister was a candidate for early colonoscopy screening. When she was diagnosed with metastatic disease, it was hard, knowing that her cancer could have been avoided, and knowing that we failed to counsel patients about actionable results. I'm here today grieving, and I wish that we had a safety net. I wish that we could protect more patients from this happening. I've been thinking about the starfish story. You may be familiar with this story. It's by Lauren Isley, and it's featured in this children's book. In this book, there's a boy and a panda and girl on a beach, and they see all of these starfish are washed ashore. And the boy asks, "What will happen?" And the panda says, "They will dry out and perish." The girl picks up a starfish and she throws it back into the ocean. The boy does the same, and so does the panda. They keep doing this, and after a while, the boy says, "There are too many. This won't make a difference." The girl then picks up another starfish, and she throws it back into the ocean. And she says, "It made a difference to him." As an individual, we can have impact. But what if we could do more together collectively? As a medical oncologist, I care for patients across the cancer continuum. My focus is on cancer genetics. Cancer genetics is all about prevention and early detection. In cancer genetics, we make family pedigrees. So circles represent females, squares represent males. My mother had a diagnosis of breast cancer, and my sister had a diagnosis of colon cancer. You can see I'm here. I'm 41 years old. In my family, I do not have a cancer gene. But when there's a cancer gene, we can use this information to counsel patients. So prior to 2013, we primarily did clinical genetic testing for BRCA1 and BRCA2. In 2021, we now have 12 genes that are associated with hereditary breast cancer. We do have large gene panels with up to 80 genes. And if patients want this information, they can have large panel testing. When there is a gene in an individual, this information is used to guide screening and to offer patients risk-reducing strategies. For example, patients who have a BRCA1 or a BRCA2 pathogenic variant, they have a high risk of breast and ovarian cancer if they're female, and males with these genes have a high risk of male breast cancer and an increased risk of prostate cancer. Both men and women can have cancer genes, and they can pass these genes down to their children. When there's a cancer gene that's associated with breast cancer, it's helpful to know whether it's associated with estrogen receptor positive breast cancer, HER2 tumors, or triple negative breast cancer. BRCA1, for example, is associated with triple negative breast cancer. BRCA2, ATM, CHEK2, and CDH1 are associated with estrogen receptor positive breast cancer. When there is an increased risk of estrogen receptor positive breast cancer, patients are a candidate for chemoprevention. We do not have preventative therapies for HER2 positive tumors or triple negative breast cancer. More research is needed. In my field, we have a few big challenges that I want to highlight. One, genetic testing is powerful. However, it's underutilized. In this study from 2012 to 2019, only 34% of patients with a diagnosis of ovarian cancer had germline genetic testing. And yet current guidelines recommend that 100% all patients with ovarian cancer should have genetic testing. So patients who should have genetic testing are not receiving it. The second issue is I believe our clinical practice guidelines are too narrow in our recommendations of who should have cancer genetic testing. We know that women and men of Ashkenazi Jewish ancestry have a higher rate of BRCA1 and BRCA2 in comparison to other ancestries, but they are not the only ancestry, ethnicity, race who has high rates of these cancer genes. Individuals from the Caribbean, Latin America, Middle Eastern, and Indian ancestry, they also have high rates of these cancer genes, and we are not including these in our guideline recommendations. I believe that we should not be organizing cancer preventative care by skin color. The third issue is that testing, screening, and preventative therapies are not covered in full by payers. So the cost of genetic testing has come down. There are now many laboratories that offer cancer genetic testing. In comparison to 3 decades ago, the cost is less. Patients can have comprehensive genetic testing for as little as $250. And I believe that if we broaden our guidelines, more patients would have genetic testing and insurers would pay for this. $250, however, is still cost prohibitive to a lot of patients if they have to pay out of pocket. It is also cost prohibitive in international settings. Even after a patient has been identified to have a BRCA mutation and they need early cancer screening with mammogram and breast MRI, there are high out-of-pocket costs to breast imaging. I recently was talking to a patient about this, and she has a BRCA mutation, and she told me that every time that she gets a breast MRI, she must pay $2,000 out of pocket. So we can do something about this. There are policies that could be in place to change this. Currently in Massachusetts, an act has been proposed. It's entitled An Act Relative to Breast Cancer Equity in Early Detection. It's going to be presented next week at the Massachusetts State House. I plan to talk at that event for 3 minutes. And I would encourage you, if you support this act to protect patients from out-of-pocket costs related to diagnostic and screening imaging, please contact your representatives in support of this act. The other challenge in my field is that demands for the workforce are too great. Before the pandemic in healthcare, we had a high level of provider burnout. Since March 2020, it's been hard in healthcare. And even though in genetics, we are not caring for patients with COVID, our workforce is strained. We do not have enough experts in cancer genetics, and we do not have enough genetic counselors. The genetic counseling workforce is this wonderful workforce. They have this high level of expertise, but one barrier to expanding that workforce is that they cannot bill for their time in their care with patients. There's a proposal at Congress to increase access to genetic counseling services. This has been proposed. I'm not sure if the Congress is going to review that, but I hope that this is passed in the future to change how we practice in cancer genetics. To go back to the personal aspect of this, I'm grieving, and when I think about my sister and how I spend my time, she would want me to spend my time in a meaningful way. And this is why I'm here today. Thinking back to this beach, what if we had tools or a safety net to change what we did for patients? What if we had big nets and we could take all of the starfish out to sea at once? What if there were more people on that beach with us? Although, for some of the things that I discussed today, there are not any immediate fixes, but while we wait for the tide to come in, there are some things that we can do now. 1, we can bring awareness to cancer prevention. 2, I ask each and every one of you to prioritize your care and your family's care. And finally, we can advocate for systems and policies that will promote cancer prevention. Thank you for coming to my TED Talk.